Welcome to PsychSummit. My name is Ryan Connor, and I'm the president of the Colorado Psychiatric Society. Together, CPS and the New York County Psychiatric Society created PsychSummit 5 years ago. We're looking forward to our series in 2024, Reimagining Community Psychiatry. Before we get into the important work for this evening, I want to acknowledge our partners who helped us realize our vision for this event. We'd like to thank the 2024 PsychSummit Advisory Panel, Doctors Mira Bodick, Nicholas Fletcher, Kenneth Minkoff, Karen Rice, Helena Winston. Thanks to the American Association for Community Psychiatry, APA Inc., and Matchbox Virtual Media for their support. And now we'll hear a short message from our platinum sponsor, PRMS.
At Professional Risk Management Services, our medical liability insurance program for psychiatrists and behavioral health group practices, the Psychiatrist Program, is designed to meet your needs throughout the various stages of your career. As a national psychiatry-specific program, a policy with PRMS can cover child and adolescent, forensic, early career, and military psychiatrists, as well as moonlighting residents and fellows, part-time practitioners, and telepsychiatrists. Learn more about how PRMS can protect you.
All right, thanks to PRMS. My name is Dr. Alan Rodriguez-Penny. I am the NYCPS president, so I represent psychiatrists within Manhattan and Staten Island. And I am excited to present PsychSummit. So this is a forum where we can have challenging and often stimulating conversations, and it's really allowing us to exchange ideas to spark change. So I want to thank all of you for your participation, and just keep in mind that the ideas we discuss tonight can actually turn into projects that we can implement together towards meaningful change. So tonight, I'd like to introduce someone who's pretty close to me in terms of a colleague, Dr. Van Yu. He volunteered his time back when I was in first year of residency to get to learn more about street psychiatry. And so with that, I've always appreciated his role in mentorship into my part of my career. And so we are going to be, well, he's actually going to be talking tonight about the intersection of psychiatry and housing. And this will be the kickoff to PsychSummit 2024, Reimagining Community Psychiatry. So Dr. Van Yu, all yours.
Thanks, Alan. It's good to see everyone. Thanks for joining us on a Sunday evening. I'm sharing my screen to pull up my slides. I was going to say, it's probably, for most of us, it's too hot to be outside anyway. So I'm happy to be inside anyway in an air-conditioned room. Okay. Can people see my slides? Someone just yell at me and say, yes, I can see them.
Yes.
Yes, great. Thank you so much. Okay, so as Alan said, we're going to talk about the intersection of housing and psychiatry. And here's what I'm going to try to do in about 20 minutes, okay? I'm going to talk fast. I'm not going to spend a lot of time on some of the slides. So I'm going to start off with a couple of slides, four slides about the scope of homelessness in the United States, like how many homeless people are there, and then go into, in the next set of slides, like some of the sort of demographic, I would say, risk factors of homelessness, focusing on mental illness, since we are psychiatrists. And I'm going to try to convince you that mental illness, when I say mental illness, I include substance use disorders in that, is one of the sort of main drivers of single adult homelessness in the United States. Then I'm going to talk about some of the interventions that have been attempted to bring to bear on the issue of homelessness and mental illness over the years, with a focus on supportive housing as, I would say, the main intervention and some of its features. And then all along, weaving into all of this, what might the role of or what has been the role of psychiatrists in all of this stuff. Okay, so on any given night in the United States of America, there are something like 600,000 Americans who are homeless. And the definition of that, there's sort of a few definitions of that floating around, but a person who's sleeping in a place, quote, not meant for human habitation. So this typically means a shelter or some other facility that's operated or supported by a government entity, or sleeping outside. And sleeping outside, you'll hear, or rough sleeping is like the term that's used a lot in Europe. I like to use unsheltered homeless. That's what I've been using recently. Okay, and then in the United States, in a given year, there are about 1.5 million episodes of homelessness, right? So an episode of homelessness can be as short as one night, or as long as the whole year, right? So so you can see these numbers are not the same. But they're connected, right? That some people are homeless for very short periods of time. I don't know, on a given night, there are 600,000 of those people. But if you add them all together in a year, all those episodes, it's 1.5 million. Okay, here it is in New York City. So I'm in New York City, so I know a lot about what's going on in New York City. And even in New York City, what I know about is single adult homelessness. So I'll say a little bit more about why that is. I don't know as much about things going on in other places. I know a little bit about what's going on in LA, a little bit about San Francisco. Almost nothing about what's going on in Colorado, by the way. So in any case, so in New York City, the Department of Homeless Services publishes a shelter census every day. It usually lags a day or two behind. And in preparation for this, I checked it on June 3rd. And there were 86,000 people in the New York City shelter system on that night. And you could divide that between singles and families. There were 20,000 single people and 18,000 families, which included 32,000 kids, right? I'm of course giving round numbers here. And let me draw your attention to the gender difference between men and women among the singles. It's a 3-to-1 difference. And that you always sort of see that ratio both among sheltered and unsheltered homeless people in the States. And I've never sort of totally understood why that is, by the way. Okay, and the focus of the next 15 or 18 minutes is single people, right? And that's because I'm going to claim to you that mental illness and substance use disorders drive single adult homelessness. It's not the only factor leading to it, but it's one of the main factors, in a way that it doesn't drive family homelessness. Family homelessness is much more driven by socioeconomic factors: unemployment, underemployment, poverty, domestic violence, things like this. And I'm not an expert on that, so I'm not going to talk about it. And then also every year, typically on a Tuesday in January or February, New York City does a HOPE count, which stands for Homeless Outreach Population Estimate. And that number was just published last week. It was 4,140 for the count done this past January, right? Okay, and then, so what does this all look like if you look at it over time? So here's the shelter census, a graph, and you'll see the first point here is the first time I gave this talk, which is August of 2010. And the shelter census that day was 35,000. And you see it's sort of gone up over the years. And then it really shot up starting in January 2022. And a lot of that's sort of migrants entering the city. And it actually hit 90,000 not too long ago. Okay. And then the HOPE count, I don't have the 24 count on this graph yet, but you see it's, this goes back to 14. It's hovering between 3,000 and 4,000 each year. So that just gives you a sense of what's going on in New York City. By the way, in a place like LA, you see the ratio between sheltered and unsheltered flip. There's about 50,000 unsheltered people in LA who are homeless, and probably 10,000 or less that are in shelters for a variety of reasons. The main reason is that, and I won't go too much into this here unless you want to ask me a question about it later. New York State has this sort of legal right to shelter that California doesn't. So one of the reasons California doesn't have a bigger shelter system, it's not the only reason, but it's one of the reasons, because they're not legally obligated to build such a thing, whereas New York City is. Okay, so I hope that gives you a sense. So if you add these numbers together, let's say there are about 90,000 New Yorkers who are homeless or who were homeless on June 3rd. So I want to give you just a sense of that number. Okay, so now what I'm going to now switch to is well, what's going on? Like, why are there so many single adult people who are homeless in a place like New York City and throughout the country? And the first bullet here, this deinstitutionalization, we're a bunch of community psychiatrists, I think. So I'm hoping I don't have to explain this too much, or that what I say here is actually maybe a little redundant for people because you already know it. So forgive me for that. But the claim here is that mental illness and substance use disorders make people vulnerable to homelessness, right? The vast majority of people, of Americans, certainly New Yorkers living with schizophrenia, for example, are not homeless, right? But it is a vulnerability to homelessness. It's like sort of like necessary but not sufficient. That's a little bit of an overstatement, but not too much, right? And typically what you need to add to the disabling condition, right, in this case, the mental illness or the substance use, is disaffiliation. If you add that to the clinical condition, that's when people really get vulnerable to homelessness, right? And then the story of deinstitutionalization, I'm going to try to do it in 2 minutes because, again, I'm assuming, although tell me if I'm correct in this assumption, that people have a basic sense of what I mean when I say I did deinstitutionalization. But basically what happened is that, starting probably in the late 50s, certainly through the 60s and 70s, there were multiple forces that sort of, there was a confluence of forces that led to the dismantling of this institutional state hospital system in places like New York. So things including issues or concerns about social justice, improvements in psychiatric medications, fiscal concerns, right? Medicaid and Medicare were both passed or came into existence in the mid-60s, and that allowed states to shift cost from states to the federal government. So all these things conspired to start emptying state hospital beds. So in the mid-50s in New York State, for example, there were something like 90,000 state hospital beds. Many of those beds were occupied by people who were living in those beds, right? So state hospitals were serving double duty. They were serving as treatment, as it was in the first half of the century, but also housing, right? And fast forward to today, there's less than 1,000 beds probably in the New York State hospital system, and people are not living in those beds, right? Okay. So so people were discharged from state hospitals, and they were supposed to live in the community and get their care from a community mental health system. One of the things that happened was that community mental health system was never sort of built up to the kind of level or robustness that would have been necessary to really serve that purpose, right? So there was like this capacity problem. And then the housing that was sort of imagined was not, I don't know what's the way to say it, maybe not well imagined or not effectively imagined. Maybe that's a better way of saying it. So that's the mental illness part of this, right? And then the housing, it just reminds me of, whenever I talk about this, it reminds me of many of you are not old enough to remember, but Bill Clinton campaigning for the presidency at one point said, "It's the economy, stupid," right? Well, this is like, well, it's housing, this is a housing problem. Well, it's a housing problem. It's housing, stupid, right? So you have a real crisis in places like New York when it comes to affordable housing. And on top of that, there's certain kinds of housing in places like New York that used to exist that were very, very cheap that really don't exist anymore, right? I think the most probably famous or infamous example, as it were, about this are flop houses. Flop houses, if you're not old enough, you might not know that term, but probably mostly people in this room know the term SRO, single room occupancy. So there's small rooms with shared facilities, shared bathrooms, shared kitchen, things like that. One of the great advantages of these kinds of housing is they were really, really, really inexpensive, right? And that kind of housing really doesn't exist anymore as a permanent housing option. There are still SRO-like programs in places like New York, but they're meant to be transitional housing. Okay. So let's move on from this. Okay, so you start as deinstitutionalization is rolling through the 60s and 70s. You start seeing the numbers of single adult homeless people in places like New York increasing over time. And I showed you a graph of that earlier. When I first started doing this in the sort of mid noughts, the homelessness, the shelter, the shelter census of New York City was like 30 to 40,000, and it's doubled since then. It's more than doubled since then. But if you actually even go back further, back into the 80s, I think that the shelter census sort of back in the 80s was less than 10,000. So it's been growing sort of steadily for the last, we're going on 40 plus years now, right? Okay, so here are the sort of interventions that have been sort of offered up in different places at different times. The first, and the thing we're going to, I think, mostly focus on in my next 10 or 12 minutes, is permanent supportive housing, right? Which is exactly what it sounds like, right? It's housing that's meant to be permanent, that provides some kind of support. The idea being that you're offering this kind of housing to people whose vulnerability to homelessness was some kind of, quote, disabling condition for which support could be helpful, right? That's the idea, right? And then there's a housing ready model of that, which was sort of the original model of permanent supportive housing. And the more modern, or the more recent model of this is this housing first model, right? Okay, so I'm going to spend a lot of time on those two models, or not a lot of time, but some time on those two models in the next couple free slides. But let me sort of list the other things, right? So there's transitional housing, and some of which, not all of which, but some of which is like contingency model housing. So things like whether you bring back a positive or negative urine tox or toxicology screen determines like what kind of transitional housing you have inside the transitional housing system. That's contingency model. Okay. Then there's, of course, the criminalization of homelessness, that people who are homeless get arrested for all kinds of things. And if we have time and you're interested, we can have a little discussion about the Grants Pass case, which is before the Supreme Court. They'll be deciding about that any day now, right? Then there's involuntary treatment. That's typically generates a lot of discussion about, well, what is the role, if any, of involuntary treatment for people who are homeless or at risk of homelessness due to their mental illness? And then is there a role for long-term hospitalization and or institutionalization like there once was? Okay, so this is sort of the list of interventions that, have as part of the point of the intervention to target the housing problem of people, right? This is a list I can think of, right? Okay, so let's talk about housing. So here's just the definition of permanent supportive housing. Permanent housing in which housing assistance and supportive services are provided to assist households with at least that should be one member with a, quote, disability. Disability is it's a term used in, it's a federal term, right? That's why I highlighted it. And the disability for the kind of housing we're talking about that makes you eligible is serious mental illness, the so-called SPMI, serious persistent mental illness, or you'll see SMI, serious mental illness, or substance use disorders, right? Okay, so the early model of this was the so-called continuum model, or housing ready is another term you'll hear, housing ready model. And the basic gist of this is that we're gonna, before we give a person a permanent home, which is a valuable resource, we're gonna get them to be housing ready. The idea being you don't want to, quote, waste a permanent housing spot on somebody who's not ready to be in it, right? The idea being that if you're not ready, you're going to flame out in some way. You're going to destroy the property. You're not going to pay your rent. You're going to fight with your neighbors, et cetera, stuff like this. That was the idea, right? Now, what does housing ready mean? Housing ready means something like you have insight into your mental illness, you take your medicine, and you don't use drugs. And any of you who've done this for any period of time should immediately realize one of the problems with this is that I don't know that many people like that, right? Like that's a population of people for whom that's a really high bar, right? On top of the situation that the mental health system you would have had to have put in place to make that happen in an effective way for the numbers of people we're talking about was never put in place. So this sort of didn't really work that well, this sort of continuing model. And the evidence of that is that the numbers of homeless people just kept increasing, right? So what ended up replacing it is a so-called housing first philosophy, right? And this was sort of another, also the result of a sort of a confluence of things happening. One, the sort of failure of continuum model housing. And two, this sort of developing, I'd say through the 90s, trend in psychiatry of like recovery-oriented kinds of ideas about psychiatry, philosophies about psychiatry. So I just sort of listed in red over there some of the like features of recovery orientation that have been borrowed by the housing people. So person-centeredness, consumer choice, harm reduction, and strengths focusing. But the basic gist of this is that instead of waiting for someone or insisting that someone be housing ready, you flip it. You house the person first, right? And then you work on their vulnerabilities. You house the person first, then you sort of address their mental illness, you address their substance use disorder, you address their primary care problems, right? And one of the ideas of behind this is that how can you expect a person to be able to effectively deal with their clinical conditions if they don't even have a house or a home to live in, right? So kind of philosophically, there's something so, I think, commonsensical about this, right? However, when this idea was first floated, there was like real concern that it wouldn't work, right? And if you think about it, like if you can imagine yourself sort of like in 1990 when Sam Sebaris is trying to get basically the first housing first program that I'm aware of in this country called Pathways to Housing off the ground in New York City, you can imagine why people would be like, I don't know if this is going to work, right? And what ended up happening, I think I'm going to skip ahead to this, where to go. Here, it is outcomes. I'll backtrack to the previous slide. So programs like Pathway to Housing get going starting in the 90s, and people start paying attention to like, well, let's see what's going to happen. Well, here's what ended up happening. There's been study after study has shown pretty high retention. Retention rates, meaning people staying in housing once placed in housing first supportive housing, in the 80+%, right? Granted, a lot of those retention studies have been done over short periods of time, like a couple of years, 3 years, 4 years, that kind of thing. There's not as many studies, or I'm not so familiar with the studies looking at like longer periods of time. Fewer subsequent shelter or street homeless periods. That sort of like goes along with the first thing. You see in populations of people in supportive housing, general improvements in mental health conditions, even if people don't engage in specific treatment, right? Now, of course, any individual person might do worse, but if you look at the whole population, the group tends to do better, meaning fewer symptoms like that, for example, right? There tends to be a reduction in substance use, although, of course, any individual person might use the same or more when moving in. But as a group, there seems to be a reduction in use. There's this interesting initial increase in healthcare utilization, which, if you think about it for 5 seconds, makes perfect sense, right? That a person who's been homeless typically is maybe too strong a word, but often hasn't had regular medical care. So once they're in housing, people start paying attention and start discovering medical problems, right? Psychiatric, substance use, and medical problems. And so you see this like uptick in Medicaid expenditures in the first year, mostly outpatient stuff, right? That then levels out in out years. And then the last thing here is, this has been a little frustrating, that even though those of us who do this believe that living in housing, helps us help you with your medical conditions. That's been difficult to show statistically to date. I believe it will be shown at some point, but it hasn't been shown as far as I know. I haven't checked in a year or so. Okay, let me backtrack for a second. And here are some of the features of this kind of housing. It's basically two things. First is your tenancy is contingent on the same thing. My tenancy, I rent my apartment here in Brooklyn, and I'm subject to the exact same landlord-tenant laws as some of my patients are who I see in their supportive housing program, right? Basically, if I pay my rent, I don't destroy the property and I don't beat up my neighbors, I can stay, right? So one of the sort of consequences, maybe not exactly the right word, but one of the outcomes or one of the things that's associated with that's a better way to say it, is that people are not required to access any of the quote support that's offered to people, which is, which is this, here's the list of things. So there's social services that help people with benefits, money management, counseling. There's social workers are often pretty good psychotherapists, care coordination, assistance with medications, and then a lot of, or maybe some, I don't know about a lot, but some supportive housing programs also are connected directly to psychiatric or even primary care services and substance use care. Okay. And then I'm going to end with like 4 or 5 photos. So this is the Christopher residence. This is, so those of you in New York City who know New York City, it might be helpful for me to give you addresses. This is 24th Street between 7th and 8th Avenue. So this is Chelsea. It's like a nice neighborhood. And this is like an old hotel. And this is 180 units. And a third of those units are a permanent supportive housing program, right? And the other third, 1/3's HIV/AIDS services, and another third's just low income, right? You can live there if you meet an income criteria. Here's an apartment in the Christopher. It's they didn't change the old hotel room footprints. So, and they're mostly studio apartments like this. And I don't know if you can tell from this photo, but it's pretty small, but then the bathrooms are really big because of the old hotel bathrooms. Here's the roof deck of the Christopher that's maintained by tenants. I've done a few sessions in that chair right there, just because I'm eating lunch and my patients pop in and talk to me. This is the Muhlenberg residence. This is Brooklyn. This is Atlantic Avenue between it's 3rd and Nevins, or Nevins and Bond. And this is another old hotel. And I was I'm no longer the psychiatrist here, but I was for a little while. And it just so happens when I accepted this posting, I was living in a building right behind this building. I could see this building from my bedroom window. And so partly I took it to as an experiment to sort of test out the community part of community psychiatry. So my patients would see me like walking my dog, taking my kids to school. There was a really good wine store right across the street from this building. My patients would see me in the wine store, right? And it worked out really well. Like I think it really helped my relationship with some people, and some of my patients definitely tell their friends, right? Like, oh, that Dr. Yu, he's like part of the community, and you can go see him. He's a really nice guy. He's a really nice dog. I would, end up having these impromptu sessions on the street corners, like stuff like this. Oh, there's a guy I used to see who was just coincidentally used the same barber I did. So we would, a couple of times we ended up in barber seats right next to each other, getting our hair cut. Not exactly having a session, but, at least chit-chatting. Here's the Schermerhorn. This is also Brooklyn. This is Schermerhorn Street and Bourne Place. Here's the back. The reason I showed this is the back of that building, because right across from those windows is State Street, which is fancy brownstones, right? So this is like in a really nice neighborhood. Here's an apartment from that building, and that's it. Those are the slides. I'm going to stop sharing. Okay, I did that really fast. I hope that wasn't too disorganized or fast.
Hello, everyone. I'm Anna Weaver. I'm the Executive Director of the Colorado Psychiatric Society. I hope all of your discussions were fruitful and you remembered to nominate someone to share the project that your team explored with the rest of the group. So let's start with team number one. Is there someone who would like to share about the discussion you had?
We had two things that kind of floated to the top. First being really resources for trainees, looking at residents and, understanding that we move through a lot of different rotations and we come in contact with a lot of different patient populations, one of them being, homelessness, and not really knowing what to do other than, once they leave our office. And so having some type of teaching curriculum, as well as just go-to resources for how we can, best help our patients when they are, experiencing homelessness. And, one of the ideas that was brought up was, partnering with AACP, looking at, some of the strengths that they have. They already have a community psychiatry curriculum out there. And this may be, someplace that or a gap needs to be filled, and we can employ their resources to do so. So I think that was and is one of our points. And the second one being, how do we as individual psychiatrists living in our own communities, how can we answer the question of homelessness for our patients? Coming up with sort of a best practices on how do we bring together, stakeholders, how do we ourselves, if that's what we're inclined to do, actually find housing, looking at grant programs that handle housing in our communities, and how can we find them and thus, kind of employ them to help those who are suffering homelessness. So it's on the training and trainees and curriculum on one side, and then the other is how do we as individual psychiatrists answer the problem of homelessness, and what are some programs out there that we can either develop or either discover, so that we can do some individual work on the ground instead of trying to come up with some large statewide policy initiative that needs to go through a whole bunch of red tape and bureaucracy.
And who would like to share from team number two?
I can take that. So our group was very similar around the need for education, especially amongst trainees. I think for some of us who've been doing this now for a while, it's hard to remember a time when we didn't know about this stuff. And to be honest, I think I learned most of that in community psychiatry fellowship. Let me put a plug in for that. You guys should apply if you're interested in these kind of things. Yeah, so just talking about kind of still how things like this aren't in kind of the usual didactics, how, residents and students can be champions of getting this talked about more, maybe inviting guests. There's some curricula out there, like you were saying, Nick, about the AACP has it. But also, the importance of getting buy-in from the program directors and the clerkship directors. So just kind of and also learning about the resources that exist in the communities where your programs are. So that's kind of what we were discussing. Some more specifics. Just learning how to work in an interdisciplinary team as a psychiatrist. Like, how do you, it maybe seems out of scope a bit because we're so used to learning about meds and therapy. Like, how much of this is the case manager, the social worker's role? How much of this is our role? Just learning more about that. And just maybe talking to people who've actually worked with homeless populations and potentially what it's like to provide services to people who are homeless, or even provide services out in the community outside of the clinics. And just, bringing more awareness to that, because I don't think it has to be scary, but there's the lack of education around this, I think, just really just adds to the angst about not potentially knowing how to work with these folks. So education, there you go.
Yeah, it sounds like a theme might be emerging. And as a reminder, if anyone is interested in one of the specific ideas discussed, reach out to us, because we will be forming work groups across the next year to work on fleshing out these ideas. So group number 3, who would like to share about your discussion?
I'll take that. First, I'll start by saying I'm so grateful to have had people from all different states in our group, because it became apparent so quickly how different the potential problems and solutions are in different states. And it's just such a great learning opportunity for me. I've been doing this for many years, but still I learned a lot just talking to you guys. I want to give a shout out for an idea that wasn't chosen, but I would love if it could be. Dr. Vasquez was advocating for a new deal that considers housing basically a federal right, a law that says people cannot be evicted just because they cannot pay rent, especially families with children. I think we are all in agreement to that. Unfortunately, we didn't really see a feasible way that that could happen in the country that we live in, unfortunately. But the idea that we seem to get some traction on was the fact that sometimes, especially in some states, people are asked to move from either shelter or their tents, encampments, whatever place they've found for themselves. They're asked to move into facilities sight unseen and without knowing where they're going, what kinds of services are available there. So some of our trainees on the group came up with the idea of having some kind of a repository where agencies that, community residencies or SROs or, housing agencies have some photos or video, list of services that they provide, something so the person who's choosing to go there can make, I guess, an informed decision, or maybe more likely to choose that place. So this is what we landed on. I'm not sure exactly how that would happen, but we all agreed that we would like to see the places that we would be told to go live at ourselves. So it would be nice to have something like that. And specifically the list of services, one of our the trainees in the group mentioned harm reduction services, needle exchanges, sharps dispensers, etc. People might be more likely to go and might be more likely to stay if they know that the place they go to looks okay and has some services on site.
Well, it sounds like there were 3 great discussions tonight. So thank you all for joining us and participating. Thank you to Dr. Yu for presenting. The next PsychSummit event will be on September 8th. So we'll be in touch by email about work groups, the upcoming event. And thank you all. Have a wonderful night.